Welcome back, everybody, to another deep dive into the MCG manual.
Today, we're taking a look at AMCI's facts to,
Remember the FTRs.
or guidelines for a bunch of cardiovascular procedures.
Yeah, let's kind of unpack that a little bit more for our listeners today.
Okay.
So we're going to be focusing on pacemakers and defibrillators, aortic valve replacements, bypass grafts, also known as CEBG,
Yes.
harvest codes,
Right.
and central venous access procedures.
That's right.
Okay, so
Lots to cover.
lots to cover.
Yeah.
Let's start with pacemakers and defibrillators.
Okay.
So, one of the things that I think is interesting about this is that,
Yeah.
we're not just talking about putting in a device. There's a lot more to it than that.
That's right.
There's a lot of specificity involved, like what kind of device, how it's implanted, all that stuff.
Yeah, you've got to know what type of device, how it's implanted, the leads involved, all that
Right.
stuff. It gets pretty specific.
Yeah, and speaking of leads, I noticed something about a third lead for biventricular pacing.
Right.
What is that?
So biventricular pacing means that we're stimulating both the left and the right ventricle.
Okay.
And so we need a third lead to do that.
So is it kind of like you're getting like the premium version of the device?
I guess you could think of it that way.
Okay.
Yeah, you're getting the full, you're fine-tuning the heart's electrical system with that third lead.
Got it.
And that would be code 33224 or 33225 for that third lead.
Okay. And what about those leadless pacemakers I keep hearing about?
Oh, yeah, those are great.
Those sound pretty futuristic.
They are. They're really a great advancement.
Yeah.
But here's a little quirk for you when we're talking about coding those.
Okay.
When you implant a leadless pacemaker, you don't code for a right heart catheterization,
Oh, interesting.
which you normally would with the other ones.
With a traditional pacemaker.
Right, exactly.
Interesting. Okay, so let's move on to the aortic valve.
Okay.
So I know that with these procedures like TAVR and TAVI,
Right.
You're often dealing with two doctors.
Yes, you do.
So that brings modifier 62 into play.
That's right.
And it's also interesting because, these codes bundle a lot of things together,
Yes, they do.
like angiography PCI, unless it's a separate session. It's almost like
Right.
it's like an all-inclusive vacation.
Yeah, they just, try to simplify things on the billing end.
Yeah.
But it just means you need to understand exactly what's included and what's not
Right.
to avoid any errors.
Yeah.
So, for example, you'd still code separately for cerebral embolic protection,
Okay.
which is often used during those procedures, and that would be 3337.
Okay, so that's something to watch out for.
Yes.
Okay. Let's move on to bypass grafts, or CABG.
Okay.
And this is one where, we've got a whole array of codes from 33510 all the way to 33536.
We do.
So if you think about it like, a highway for the heart,
Mm-hmm.
are we basically coding for each lane that we add?
Not each lane,
Okay.
but I like the way you're thinking.
Okay.
The codes reflect the number and type of grafts that are used, whether they're veins or arteries, to bypass those blockages.
So more complex, bypass more codes.
That's right.
Okay.
And here's where it gets a little tricky.
Okay.
Most of the time, the harvesting of those grafts is bundled into the main codes.
Okay.
But there are some very specific exceptions.
What are those exceptions?
So if they use an upper extremity vein, that's a separate code.
Okay.
That's 35500.
Got it.
Upper extremity artery is 33509 or 35600.
Okay.
And then if they use a portion of the femoral vein, we're looking at 3572.
Okay, so some harvests are bundled, others have their own separate codes.
That's right. And before we move on from bypass grafts,
Okay.
we should touch upon percutaneous ventricular assist devices, or PVADs.
Okay.
And those are coded separately for insertion removal and repositioning.
Okay.
And those codes are 33990 to 33995 and 33997.
All right, so PVADs are their own little category.
Yes.
Okay, that brings us to those harvest codes that we mentioned earlier.
Okay.
And if I'm sticking with this highway analogy,
Yeah.
I'm picturing them as the construction crews,
Yeah.
gathering the materials for the bypass.
That's a great way to put it.
And we know that some are bundled, some aren't.
Right.
So can you remind us of the key takeaways there?
Yes. So when we're talking about harvesting the saphenous vein or the internal thoracic artery,
Okay,
those are typically bundled.
got it.
But as we discussed earlier, those upper extremity veins and arteries,
Right.
as well as portions of the femoral vein,
Yeah,
those get their own separate codes.
right. They've got their own codes. Okay.
Yeah.
And I know there's also something about composite grafts as well, right?
Yes. Those are fascinating.
Yeah.
Composite grafts are when surgeons combine multiple segments of veins or arteries to create a longer graft.
Oh, wow.
And there are specific codes for those.
Okay.
35682 if it's 2 segments.
Got it.
35683 for 3 or more.
Wow. It's like they're creating custom-built bypass roads.
That's a great way to think about it.
So we've covered pacemakers, we've covered aortic valves, we've covered bypass grafts. We've even covered harvest codes.
We have.
What's next on our little coding adventure here?
Let's dive into central venous access procedures.
All right.
And this is where things can get a little tricky,
Right.
but those FTRs can really help us navigate these water.
All right, we'll lead the way.
Okay, so the key thing to remember with these procedures is location, location, location.
Okay.
Where that catheter tip ends up.
Okay.
Is it in the subclavian vein, brachiocephalic right atrium?
So it's like having a GPS for your veins.
I like that analogy.
Okay.
You need to know exactly where it's going.
Make sure it goes to the right spot.
Yes, and there's a whole checklist you need to go through when you're coding for this.
Oh, really?
Catheter versus device age of the patient's central versus peripheral access tunneled or non-tunneled pump or port.
Wow. It's a lot to keep in mind.
It is a lot to keep in mind.
So I can see how, coding for this could be a challenge.
It can be.
Yeah.
And here's a common mistake people make.
Okay.
Midline catheters are not PICCs.
Okay, so midline is not a PICC.
Correct.
Got it.
That's a very common mistake people make.
This is all incredibly helpful, but I think my brain needs a little bit of a break to process this information.
Okay.
We'll be back in a flash to continue our deep dive, exploring more of those FTRs and coding conundrums.
Sounds good. You know, it's amazing how these coding guidelines, especially those FTRs, really force you to think like a surgeon.
Yeah.
You know, understanding the why behind each step of a procedure,
Yeah.
it really makes all the difference in choosing the right code.
Yeah, it's true.
Yeah.
It's like we're not just assigning numbers. We're translating these really complex medical procedures
Right.
into a language that insurers can understand.
Exactly.
And, accuracy is crucial not just for reimbursement, but also for, patient records.
Absolutely.
To make sure that they're accurate.
Yeah, let's shift gears a little bit and delve into a different type of cardiovascular procedure here.
Okay.
We're going to talk about embolectomy and thrombectomy procedures.
Okay.
These are codes 34001 through 34490.
So we're talking about removing blood clots.
That's right.
And those can be pretty serious.
They can be very serious, life-threatening in some cases.
Yeah.
And just like with those other procedures we talked about, coding for these requires a high level of detail.
Okay.
We need to know, is it an artery or a vein?
Okay.
The location of the clot,
Okay.
and then the method used to remove it.
So are we talking about different techniques depending on, where the clot is?
Exactly. There are different approaches,
Yeah.
depending on if it's, in a leg artery or a neck artery or even in the lungs.
Wow.
And the coding reflects those different approaches.
So it's not just about removing the clot, it's about
Yeah.
understanding,
Right.
the entire pathway to get there.
That's a great way to put it.
Yeah.
Now, here's a little coding tip that might come in handy.
Okay.
The term embolism refers to a clot that's moving through the bloodstream,
Okay.
while a thrombus is a clot that's stationary.
Okay, so embolism is moving, thrombus is stationary.
Yes.
Got it.
That distinction can be important when you're selecting the right code.
It seems like every little detail matters when it comes to this.
It really does.
Yeah.
All right, ready for another set of codes?
Hit me with it.
We're going to move on to endovascular repair of abdominal aortic aneurysms, or AAAs,
Okay.
and iliac arteries. These are codes 34701 to 34834.
Right.
And these can be a little tricky.
All right.
There are a lot of variables involved,
Like what?
such as the location of the aneurysm in relation to the renal arteries, the type of prosthesis used,
Sure.
whether any extensions are needed.
So it's like a puzzle,
Yes,
trying to fit all the pieces together
that's a great way to think about it.
to arrive at the right code.
Now, something else to keep in mind.
Okay.
Any additional treatment that's done within the treatment zone,
Yep.
which is the area covered by the endograft,
Uh-huh.
that's bundled into those main repair codes.
So it's important to visualize that treatment zone
It is.
and understand what falls within that boundary.
Exactly. And speaking of things being bundled,
Yeah.
fluoroscopy, radiological supervision, and interpretation, even non-selective catheterization,
Oh, wow.
those are all included in these AAA repair codes.
Okay, so lots of things bundled in there.
Yes.
What about procedures done outside of that zone?
Those would be coded separately.
Okay, got it. And what about ultrasounds?
Ultrasounds are coded separately as well.
Okay, so we're keeping track of what's bundled and what's not.
Yes.
Any other coding tips for these AAA repairs?
Yes. Remember that a true aneurysm
Okay.
involves all three layers of the artery wall,
Okay.
while a pseudoaneurysm does not.
Okay.
Knowing the difference can help you select the correct code.
Wow. It's like we're getting an anatomy lesson along with our coding deep dive.
I told you this was fun stuff.
Yeah.
Now, how about we move on to fenestrated endovascular repair of the aorta?
Okay.
This is codes 34839 through 34848.
Fenestrated, that sounds pretty high-tech.
It is. It refers to a special type of endograft that has small holes or fenestrations built into it. And these holes allow blood flow to branch arteries that come off the aorta that might otherwise be blocked by the endograft.
So it's like a customized endograft.
Yes.
With little windows for those important arteries.
And just like with standard AAA repairs, certain procedures like angioplasty and fluoroscopy are bundled into these fenestrated repair codes.
Okay, so that bundling concept applies here as well.
It does.
It seems like we're starting to see some patterns emerge.
You are.
Which is good.
Recognizing those patterns is key to mastering medical coding.
Okay.
And we're going to stick with that bundling theme as we move on to direct repair of aneurysms or excision.
Okay.
This is codes 35001 to 35152.
Direct repair. So we're talking about open surgery in this case.
You got it.
Okay. And with open aneurysm, repair certain procedures that might be coded separately in other scenarios are bundled into the main repair code. For instance, preparing the artery for anastomosis.
Which is connecting the ends of the artery.
Okay.
And performing an endarterectomy, which is removing plaque from the artery.
Okay.
Those are both considered part of the direct repair procedure.
So it's like a package deal.
Exactly.
Okay.
Now, how about a quick detour back into the world of harvest codes?
Always happy to revisit those construction crews gathering materials.
So these codes are thankfully pretty straightforward.
Okay.
Remember how we talked about harvesting veins and arteries for bypass grafts?
Yes. And it was all about where those grafts were coming from.
That's right.
And whether or not they were bundled.
Exactly.
Yeah.
So here's a quick recap.
Okay.
When it comes to harvest codes, the procurement of saphenous veins and internal thoracic arteries, those are typically bundled into the main CAB codes.
Okay. That part's pretty clear.
Yeah.
What about the rest?
But there are specific codes for harvesting from other locations.
Okay.
For instance, harvesting an upper extremity vein is coded as 300/500, while harvesting an upper extremity artery gets code 35600.
Got it.
And if a portion of the femoral vein is used, that's code 35572.
Right. Those are the exceptions.
Exactly.
Of the bundling rule. They have their own dedicated codes.
You got it. And don't forget about modifier 80. Which is used when a surgical assistant performs the harvest.
Modifier 80, the surgical assistant's trusty companion.
Now, before we move on, I want to highlight those codes for composite grafts again.
Yes. Those are fascinating.
Remember, those are the grafts made by combining multiple segments.
It's like they're creating custom-built blood vessels.
Exactly.
Yeah.
So if a composite graft is created using two segments from different locations, that's coded as 35682.
Got it.
And if 3 or more segments are used, it's 35683.
Okay, so we've got a code for each level of complexity.
That's right.
When it comes to those composite grafts.
It's a great example of how the level of detail in medical coding reflects these incredible advances in cardiovascular surgery.
It really is. It's mind-blowing what they can do these days.
It is.
And it's fascinating to see how each step of those procedures is, reflected in the coding.
It really is. Medical coding is like this hidden language that unlocks all the intricacies of these procedures and ensures that healthcare providers are properly reimbursed for their expertise.
Well said. This deep dive has been incredibly enlightening.
Good.
But we're not done yet.
No.
We've got more fascinating FTRs to explore.
We do.
We'll be back shortly to continue our journey through the world of cardiovascular coding. Okay, we are back and ready to wrap up our deep dive into cardiovascular coding.
Using those FTRs.
Oh, yes, those FTRs. And
you're going to be a coding ninja by the time we're done here.
I'm feeling like a coding ninja at this point.
Okay, good.
I'm ready for anything.
Let's put those ninja skills to the test then.
Okay.
All right, we're going to explore the world of diagnostic studies of the cervicocerebral arteries.
All right.
These are the blood vessels that supply the brain.
Okay, very important.
Yes, very important.
Right on.
And these often involve what we call a cervical cath, where a catheter is inserted into an artery, usually in the neck or the arm, to visualize those arteries.
We're talking about getting a detailed roadmap of the brain's blood supply.
Oh, exactly.
Which sounds pretty important.
It is crucial for diagnosing and treating conditions that affect blood flow to the brain, like strokes or aneurysms.
Right.
And as with all the procedures we've discussed, coding for these studies requires careful attention to detail.
Of course.
And the codes range from 36200 to 36218.
Okay.
And these depend on a number of factors.
Okay, what are those factors?
So we need to know whether the study is focusing on arteries above or below the diaphragm,
okay,
which specific branches of the arteries are examined,
okay,
and whether the approach is selective, meaning they're targeting specific vessels,
okay,
or non-selective, kind of taking a broader view.
So it's like choosing different levels of magnification.
Yes, I like that. So are we zooming in on specific arteries or getting a wider angle shot of the region?
Exactly.
Now, a key coding principle here is that you always code for the highest order branch that's examined.
Okay, so if they look at a first, second, and third order branch,
yes,
we would code for that third order branch.
Yes, because it's the most specific.
Because it's the most specific. Got it.
You're getting this?
I think so.
Okay, good. Now, another important point.
Right.
Certain procedures that might be coded separately in other contexts
Okay.
are bundled into these diagnostic study codes.
Like what kind of procedures?
So things like interventional angiography,
Okay.
which involves using imaging guidance to actually perform procedures within those blood vessels.
Wow.
Fluoroscopy is also bundled in,
okay,
as well as closing the artery after the procedure.
So it's another one of those package deals.
It is.
Got it.
Now let's focus specifically on those diagnostic studies that look at arteries above the diaphragm.
Okay.
These are coded using 36221 through 36228.
Okay, so we're zooming in on those upper body arteries.
We are.
What makes these codes different?
So in addition to the factors we already mentioned, selective versus non-selective, highest order branch examined.
Yeah.
These codes also take into account whether the study is done bilaterally.
Oh, so on both sides of the body.
On both sides of the body, yes.
And if they are, we need to indicate that.
We do.
How do we do that?
We use modifier 50.
Modifier 50.
Think of it as our ×2 signal.
Okay, modifier 50. Got it. Any other modifiers that we need to be aware of?
Yes. If the study involves examining different arteries, like, say, both the vertebral and the carotid artery, we use modifier 59 to indicate those are distinct procedures.
Okay, so we're adding these modifiers to give that extra level of detail.
Exactly.
Specificity.
Now let's wrap up our discussion of cervicocerebral artery studies by looking at codes 36245 through 36248. These cover those diagnostic studies of lower extremity arteries below the diaphragm.
Okay, so now we're going from the head and neck down to the legs.
We're moving down.
Okay, what do we need to know about these codes?
So much like those upper extremity codes, these consider whether the approach is selective or non-selective. Okay. The highest order branch examined. But here's where it gets interesting.
Okay.
Some of the procedures that were bundled into those upper extremity codes are actually coded separately when we're talking about lower extremity studies.
Okay, so give me an example.
So things like interventional angiography and fluoroscopy, those would have their own separate codes if they're performed during a lower extremity study.
Okay, so we need to pay close attention to whether we're dealing with upper or lower.
We do.
Because those bundling rules can change.
They can.
Depending on the location.
Exactly. And those FTRs are essential for navigating those subtle but important differences between those code sets. Now, are you ready for our final challenge?
Bring it on. I'm feeling confident.
All right. Let's tackle central venous access procedures.
Okay.
These are codes 36555 through 36573.
Right.
And these involve inserting a catheter into a large vein, typically in the neck, chest, or groin, to administer medications, fluids, blood products, or even monitor blood pressure.
Okay, so we're talking about those major veins access.
Major vein access, that's right.
Seems pretty straightforward.
Yeah, but the catch is...
What's the catch?
Coding these procedures involves considering a number of factors.
Oh, boy.
And the FTRs are our guide through this coding maze.
Okay, all ears, walk me through it.
All right, so first and foremost, we need to know where that catheter tip ends up.
Okay.
Does it terminate in the subclavian vein, the brachiocephalic vein, the iliac vein, the inferior or superior vena cava, or even the right atrium?
So it's like those GPS coordinates again. We need to know exactly where that catheter is going.
It's location, location, location.
To choose the right code.
And in addition to location, we also need to consider, are we dealing with a catheter or a device? the age of the patient, whether the access is central or peripheral, whether the catheter is tunneled or non-tunneled, and whether there's a pump or a port involved.
Wow, that's a lot to keep track of.
It is a lot. And just when you think you've got it all figured out, there's another layer of complexity.
Oh, no.
There are specific guidelines for coding these procedures based on whether imaging guidance is used.
Got it.
And here's a common coding pitfall. Midline catheters, which terminate in a large vein but not in the central circulation, should never be reported as PICCs.
Okay, so midline is not a PICC.
Midline is not a PICC.
Got it.
They are distinct procedures with different kinds.
This has been an incredible deep dive.
It has.
We've covered so much ground.
We have. It's been quite a journey through the world of cardiovascular coding.
But those FTRs are our friends.
They are your friends.
They're there to guide us.
They're there to guide you.
Through this, very intricate world of CPT coding.
Exactly.
And ensure accurate reimbursement for these really essential procedures.
It really is essential, and it is a complex area.
Absolutely.
But hopefully this is giving you a little bit better understanding of it.
Yeah, I feel like I've gained a whole new understanding of cardiovascular coding.
Good. I'm glad to hear that.
And those FTRs are definitely going to be my go-to resource from now on.
That's great. And remember, the world of medical coding is constantly evolving.
That's true.
So stay curious, keep learning, and never hesitate to ask questions.
That's great advice. And to our listeners, we encourage you to dive deeper into that MCG manual.
Please do.
And explore those AMCI resources. It's like having a secret decoder ring.
It is.
For medical billing.
Keep those coding skills sharp.
Yes.
And we will see you on our next deep dive.
Thanks for joining us. Until next time, happy coding.